Thank you again for the invitation. It's a pleasure to be here with you. It's always a pleasure to be here. I have come several times to your meetings, and I think you're doing a fantastic job on organizing things. I will speak about the role of imaging in atrial fibrillation. Personally, I think imaging does not have a role in predicting who is going to get atrial fibrillation. And imaging is also not having a key role in that you can predict who get a relapse after AF ablation. But it does give you circumstantial evidence on what's going on in this heart. So I think what is important that you realize that we can measure LA size and LA function, mostly with echocardiography, and this has implications for which one to ablate and which one probably not to ablate, because you can derive a sort of estimation who will have likely success and who will have not likely success. So I'll take you slowly through this, simply by examples. So here you see what are the main predictors of AF recurrences after catheter ablation. And the ones that are clinically relevant is age, hypertension, permanent atrial fibrillation. But in addition to, let's say, these non-imaging markers, we also have two imaging markers that are important, which is LA dimensions and LV dimensions. And these are just anatomical measures, if you like, dimensions. But probably what is also important is the function of the atrium. How good is this atrium functioning? I think the first question that comes then to us is, how do we actually define best LA size? How do we really define that? And we have echocardiography with different ways of doing that. We can look at the linear dimensions, which is the easiest way of doing that. And by doing that, we take usually this long parasternal axis view, and we just cut an M mode. An M mode is the easiest way to cut. You just cut through here, and then you cut the left atrium. And it's important to note that you cut it in the anterior-posterior diameter. And here you see that, what it looks like then on the M mode, and we can measure that. If we measure that, we come to numbers as such as here, and here you see it directly measured from a 2D, which is actually the same as the M mode, and this gives us dimensions, M mode dimensions and linear dimensions. And we have normal values for that. People develop normal values, and you see here, this is when you call something severely abnormal. And the one you look at is the LA diameter. If it becomes over 5.2, or if you normalize it for body surface area, what people like to do, it becomes over 3 when it's severely dilated. But what is important to realize is that it is not actually a very symmetrical structure, an atrium. It's often very asymmetrical. And the asymmetry may occur in the medial lateral axis or the superior inferior axis, and not so much on the dimension that we measure on M mode. Why not? Because the thoracic cavity is restricting there. It can simply not dilate in that direction. And once I've trained in echocardiography, there was a technician who always explained to me, atrial fibrillation, the atria look like Spanish tomatoes. They don't dilate here, but they dilate here. And why is that? That is because since LA enlargement is actually limited in the anteroposterior axis by the thoracic cavity, it can simply not extend much there. So the LA anteroposterior dimension is probably not an accurate reflector of LA volume, particularly when we have LA enlargement. So this is probably, we have looked always at that, but not the easy way forward. Then we start to move in the 4-chamber views. We take now the 2-dimensional imaging, and you get the 4-chamber views and the 2-chamber views, and we get this sort of long axis and short axis that we measure. And the first question that actually comes to one, okay, when do we measure? Do we measure with the mitral valve open or the mitral valve closed? And how do these two differ in the 4 chambers and the 2 chambers? So we realized that we want to go in the direction of volumetric measurements. We want to go in the direction of three-dimensional, eventually, actually moving images where we can measure the accurate assessment of size. So volume determinants are preferred since they allow accurate assessment of the asymmetric remodeling of the left atrium, as I just pointed out to you. There are stronger relationships between cardiovascular disease and LA volume than if you relate it with LA dimensions. And there is a good agreement between three-dimensional echo measurements of LA volume and when you compare them with CT and MRI measures, although there is a slight underestimation by echocardiography. So we move from M mode to 2D, probably to 3D, to get the best assessment of an atrium. And then if we want to go in the volumetric directions, we have all these different measures that you can do. And the one that is used most often is the modified Simpson's rule. This is the summation of discs. You take in the 2-chamber and you take in the 4-chamber and you get all the different cuts, and based on that you derive artificially a volume. Here you see that how that's being done. You take the 4-chamber and you take the 2-chamber and you just trace it, and from that he derives for you the formula, the volume. What is important to know is that when the valve is closed and systole, you have the largest LA volume, and usually that's what people use. Here you see an example of that again, and what most of us do is that we again we relate it to body surface area. So we don't take the real volume, but we relate it to body surface area, because a larger person has probably a larger volume. Also for that, they have developed normal values, and you see here an LA volume is abnormal when it's more than 79, and when you normalize it for body surface area, is more than 40. And then this three-dimensional echo started to come, and this is a ventricular automatic assessment. You take this from the 4-chamber, the 2-chamber, you trace it, and you get an automatic assessment, and this is a quite accurate measure. It's not foreshortening. You can do it at any time of the cardiac cycle, and it agrees quite well with magnetic resonance imaging. So this is probably the way forward. So what you can do on the ventricle, we started to actually use the same algorithm and apply it to the atrium. You just trace it here in the 2 and the 4 chambers, and then you get the real dimension of the left atrium. This is actually really an accurate measurement. The first thing you'll ever see is that there is a big change in volume over the cycle. And if we now speak when is an atrium enlarged, the question that comes is when do we actually take the measure? You see that even better here when you look at this MRI. Here you see that the LA volume really changes over time. So when is the momentum that we take the volume to say, oh, this one is normal and that one is abnormal? When do we do that? There is no good answer for that. But it is important to realize that if you use real 3D imaging, that you have a maximum volume, which is just before mitral valve opening. You have a minimum volume, which is just before mitral valve closure. And we have what we call LA pre-A, which is the last frame before mitral valve reopening. And here you see the volumes, how they change over the cycle. LA size is important to think about physiological correlates. LA does increase with body size, that's why we normalize for body surface area and gender, but it does not increase that much with age. So these are the physiological correlates. What is important to realize, and that's when we come in the direction of development of atrial fibrillation, what is important to realize is that there are pathophysiological correlates. What happens when you have pathologies? For me, this was quite a very good article impressing that. So LA increases with left atrial pressure overload, such as occurs in mitral stenosis with increased LV filling pressures, secondary to systolic or diastolic dysfunction. That is LA pressure overload. But you can also have LA volume overload, which occurs, for example, in mitral regurgitation, high cardiac output states, left to right shunts, and AV fistula. So we have pressure and volume, and both of that result in large left atria. Is that important then, that the atrium get larger? Yes, because the LA size is very important for prognosis. LA increase is predictive for atrial fibrillation and stroke, ischemic heart disease, all-cause mortality, and outcome after infarction. Probably they all relate to the same diseases, and probably most often it is atrial fibrillation development secondary to this enlargement, which is then related to the prognosis. And you see here, if you have very large or small atria, that the outcome significantly differs in stroke. LA size, LA increasing size, is also predictive for outcome after acute infarction. You see here the LA volume, and when it goes up, mortality goes up also. But again, this is probably indirecting, also reflecting atrial fibrillation. Larger size results in more atrial fibrillation, results in more events. Now let's switch from LA size to LA function. So I talked to you about anatomy, how big is it? Now we switch to function. LA function, first the physiology. LA modulates LV filling through these three. And if you want to remember anything of this talk, it's probably important that you remember this here. We have three components of function. We have the reservoir function, we have the conduit function, and we have the booster pump function. The reservoir function is the function that during LV systole and IVR, isovolumetric relaxation, the LA receives blood from the pulmonary veins and acts as a reservoir. It's filling up. Then we have the conduit function, which happens during early diastole and diastasis. Then the left atrium acts as a conduit. The blood is passively moved from the atrium to the ventricle. And probably this is the most important part, the booster pump function. This is at the end of diastole, when the left atrium acts as a pump by LA contraction, and it's specifically that part that we lose when we develop atrial fibrillation. So you have these three components here that are particularly important when we speak about LA function. We have just spoken about how the LA influences the LV, but the LV function, vice versa, also affects LA function. We have the reservoir function again is modulated by LV contraction, because LV contraction in the beginning is this up and down motion. Also RV systolic pressures transmitted through the pulmonary circulation, LA relaxation and LA stiffness. All of that has an influence. The conduit function is modulated by LV diastolic properties, which is LV relaxation, early diastolic pressures. And finally, the booster pump function is also modulated by LV compliance and LV end diastolic pressure. So the atrium influences the ventricular function, and the ventricular function influences the atrial function. How to define best LA function is then the next question. We can do that very simple. We can take the transmitral inflow, as we all know here, where you have an A, an E, and an A, and the A is the late part. So this is pulsed wave Doppler, where you measure the peak wave A velocity, is the late part, is reflecting in a way the booster pump. We can do the A wave time velocity integral, that we just trace this and calculate specifically. We can also do the atrial fraction, where we take the TVI A wave over the TVI mitral inflow. So we trace everything, and then we take this part here and see how much it is. All of that is dependent on heart rate and loading conditions. So we like to have some better way of measuring. And this is tissue Doppler imaging, where you have a color-coded imaging of the ventricle, and then if we put the samples here on the heart, we get no longer something dependent on heart rate and blood flow, but we get something that is dependent only on the velocities of the myocardium. That's what it reflects. So this is quantification of diastolic velocities, where the E prime is the early diastolic velocity and the A prime is the late diastolic velocity. And it's again this late diastolic velocity that's the booster pump function. So if you want a quick shot to assess what is the booster pump function, you do the A prime late diastolic velocities. And these myocardial velocities, they don't depend much on loading conditions. And then we can take one step further with advanced echocardiography, and that is that we put a sample here and that we do strain imaging, which is the active deformation of the left atrium. This is not yet used a lot in clinics, but we see it coming more and more. Probably the best way to do it at this moment in time is to use the volumes. And again, as I said, we have the three volumes, the LA max, the LA min, and the LA pre-A, which we discussed earlier. That comes from the 3D acquisitions. And I'm not going to go into these formulas, but what you see here is that the booster function, the conduit, and the reservoir can be calculated from these three volumes that you take over the cycle. So again, this is the most important one, and we can calculate that based on these different formulas. What else is important if we speak about the atrium? There is a third part that's probably the most important. And probably all of those three are interrelated. The size, the function, and the third player is the LA fibrosis. And probably pressure and further dilatation results in LA fibrosis, and LA fibrosis results in reduction of LA function. So size, dilatation, fibrosis formation, and LA function going down. And it's probably the interplay of these three that eventually gives us atrial fibrillation. So how do we measure that fibrosis? We can do it directly with MRI, I'll show that to you in a second, but we can also do it with this, again, this tissue Doppler. When you do the tissue Doppler and you put the signal here, for example, then you have an ECG tracing here. Here is the P wave. So this is electricity. And here you see then these E prime and the A prime, as I just indicated to you. And the time interval between the P wave and the A prime is a marker of electrical mechanical delay. And that reflects actually fibrosis. So you have electricity, then it takes a long time to travel because there's a lot of fibrosis, and then you get a booster pump. And the booster pump, again, you pick from the PA-TDI. So if you look at that, you see that actually here we took almost 500 patients, 20% with previous paroxysmal atrial fibrillation, and we looked at the PA-TDI, if it was predictive for these heart failure patients to develop atrial fibrillation. And we saw the ones that have a long PA-TDI and the ones that have a short PA-TDI, that the ones with the long PA-TDI develop much more atrial fibrillation. The long PA-TDI, very simple to get from these echo images, is a marker of electrical mechanical delay, which is a marker of LA fibrosis. So I tried to show to you size, function, fibrosis. It is these three that actually eventually most likely develop atrial fibrillation. Here you see a patient with a short PA-TDI, 110 I think it says there. Here you see a patient that develops atrial fibrillation. It's very easy to pick up the much longer duration. It sounds complex, this, but it's very easy to assess that in the echo lab. So you asked me how to predict, and I tell you, I think this is the way to predict what's going to happen. It will never be the case that you say, oh, if you have 50, you don't get atrial fibrillation. If you have 60, you do get atrial fibrillation. But what will be, it's an additional marker. The bigger the size gets, the more fibrosis, the booster pump function goes down, and you probably, over time, develop atrial fibrillation. There is one other echo technique that you can use. This is called integrated backscatter. This technique is a simple technique, but it's not very useful for the individual, but for the global population, it gives us an idea. This calibrated integrated backscatter is actually the tissue ultrasound reflectivity that you measure. And that is also a marker of LA fibrosis. Here you see different, here's the septum, here's the posterior wall, this is the pericardium, and this is the measurement in the atrium. And this gives you then decibel values. And if the decibel value goes in the direction of 0, that means that there's a lot of fibrosis, which is here in the pericardium. And I'll show you just the results of one study that we did. Here's 170 patients. 71% has paroxysmal atrial fibrillation. And first we looked at the size of the atrium. So these are the small atria, these are the large atria. And this here is this decibels on the y-axis, and the decibels actually represent the fibrosis. So if I go more in the direction of 0, I have more fibrosis. The small atrium has less fibrosis than the large atria. You see here that this gets more in the direction of 0. But you immediately see also that there is a huge difference. You have some that are having very fibrotic left atria and some that are actually not having a lot of fibrosis. And so this gives us an extra idea that it's when the size gets bigger, you usually have more fibrosis, but not always. You can also have a small atrium where the function is already down and you still have a lot of fibrosis. We can measure that with MRI. This is delayed enhancement, contrast enhanced MRI, and you see this whitish here, that is where fibrosis is formed, and this is a patient after ablation. So we have ablated around these pulmonary veins here, and you see that scar formation fibrosis is coming there. And these people from Utah actually have developed a model with MRI where you can visualize the fibrosis in the atria, and that greenish is the fibrosis. This here has very little enhancement, so very little fibrosis. But these ones here have a lot of fibrosis. So actually these ones are most likely to develop more and more atrial fibrillation, more difficult. These ones are the ones that are not likely to develop atrial fibrillation, and these ones are also easy to ablate because there is no substrate yet. But these ones here have a lot of fibrosis and very difficult to ablate because you cannot take away the fibrosis, you don't take away the trigger. And they've looked at atrial fibrillation recurrence after ablation in the ones with very little fibrosis, nothing, and in the ones with a lot of fibrosis, huge recurrences. So step by step, I brought you during the talk from size to function to fibrosis, to development of atrial fibrillation, and to possibly how to ablate atrial fibrillation. Which ones can we ablate, which ones we cannot ablate. The last few slides that I have are the evaluation of successful ablations. We can look again at dimensions and function, and we can look at LV performance. So what we see, if we ablate the patient successfully, that actually these in green are the ones where we restore sinus rhythm, we reduce the size, the diameter, and we also reduce the volumes. But the ones that fall back in atrial fibrillation, the red, they actually start to dilate further and they get bigger volumes. We also saw the same pattern on the 3D. The ones that stay in atrial fibrillation or relapse in atrial fibrillation get bigger volumes, whereas the ones that go in sinus rhythm get smaller volumes. And the last two slides that I have, something is happening also on the ventricle when you ablate successfully. And we can measure that with left ventricular strain, left ventricular deformation of the myocardium. If we look at a patient like this, where you have a normal function, normal EF, you would say probably before ablation, and this is the situation after ablation, did nothing happen for this ventricle? Is nothing good happening for that AF ablation? But this is what you see when you look at the strain maps. Here the global strain is -16, so it's reduced because a normal strain is actually around 20, and you see that there are areas here where the strain is not good. And when you do the follow-up after successful ablation, you see that the strain normalizes. So when you ablate successfully, something good is happening for the ventricle also. I've tried to show you stepwise, that's why it went a little bit slow, but stepwise, echocardiography can assess LA size and volumes. The volumes are eventually preferred. Echocardiography can also assess LA function. We have this normal way of measuring, but I believe that this tissue Doppler and the strain will give us more additional information. Echocardiography can then also assess LA fibrosis. Probably MRI will be preferred, but this technique is quite difficult. Actually, I went myself 2 weeks ago to Utah to see how that works, and it's not an easy technique to apply. LA function and fibrosis together. Function, volume. Function, dilatation resulting in fibrosis can be used to predict atrial fibrillation development and the success of AF ablation. Do not expect that if you have this or this or this, never atrial fibrillation will occur, or always atrial fibrillation will occur, because that's not how it works. It's an additional marker that gives you a little bit certainty that the likelihood that you develop atrial fibrillation or that you cannot ablate successfully is higher. So use it as circumstantial evidence and not as the one to guide your therapy. Echocardiography can demonstrate changes in LA size, function, but also LV function after successful AF ablation. Something happens on the atrium, that's sure, but also something happens on the ventricle. Thank you very much.